I've got 10 o'clock on my clock here, so let's get started on this webinar. I'll start with introducing myself. Thank you all for joining this special webinar today. It's specific to one of the main challenges in healthcare industry. We're going to be talking about the Safe Patient Handling Program. But my name is Sarah Snable. I'm one of the co-founders of PROergonomics, and I'm going to be presenting with you this morning. So I'm really excited to be talking about this topic. It's a really widespread challenge that the health industry faces. That's reducing injuries for our frontline healthcare staff. And before we really get started in diving into this, I wanted to give you some basic webinar tips here, just if you're not familiar with using AnyMeeting or if you haven't joined one of our webinars in the past. So I'm going to be presenting, but along the left side of the screen, you're going to see a chat bar. That's the bar that you can use throughout the webinar to ask any questions or provide any comments. And my partner, Alex Stinson, is logged in as well today. So she's going to be helping me field any questions, just because I'll be spending my time talking, obviously. So it will be she's there to kind of help. You have the option that you can send your comments or questions so that everyone attending today can see, or you'll notice there's a little drop-down menu, and you can also send just to the presenters. Either way, us as the presenters will see everything that comes in, so we'll try not to miss any questions. In terms of technical difficulties, I can't necessarily help with those, like in terms of you getting connected, but if you hear my voice fading in or out, or if it sounds like I all of a sudden jumped away from my mic, those are the things you can use the chat bar, and I can kind of fix that throughout. It could be just a small little adjustment I need to make on my end. So on that notice, let's continue on. I want to tell you a little bit about PROergonomics. Our website has a lot of details on the types of services that we do, and so by all means this isn't a comprehensive list, but in terms of what we're talking about today, one of our main focuses is that we do training of all different types. Sometimes it's a short little lunch and learn or a webinar, maybe half an hour to an hour, to multi-day sessions for joint health and safety or ergonomic committees, as well as risk assessments, PDAs, return to work assessments. Definitely, if you're not familiar with some of the work that we do, I can help out with that. Again, looking at the list of attendees today, I know that some of you are already clients of ours, but not all of you, so I wanted to give you a little bit of background information on PROergonomics. All of the partners at PROergonomics are certified professional ergonomists, which means that we have this educational background in kinesiology and human factors, as well as a very diverse work experience in all the different aspects of ergonomics, and that make us eligible for that designation. And all of our staff at PROergonomics we're also all registered kinesiologists with the College of Kinesiologists in Ontario, and members of ACE and OKA, so that's the Association of Canadian Ergonomists and the Ontario Kinesiology Association. We really strive to be professionals in all that we do, and we really put a strong effort on a team approach to working with our clients. We really try to help use that team approach to develop those customized solutions for our clients. So each of us have slightly different niches and work backgrounds, and we really try to collaborate with each other to make sure that our clients are really getting the most effective and innovative solutions. Speaking of work background, my start in the field of ergonomics in particular was in healthcare. I worked for Hamilton All Sciences both as a co-op student when I was at university, and then also as a full-time in-house ergonomist or kinesiologist. I had multiple titles for several years afterwards. So as you know, there's lots that can be done as an ergo in a hospital, and I was definitely kept busy in all different departments and across multiple sites. So I worked with porters and food services, housekeeping, office staff, and of course, obviously the frontline care providers. That was the nurses and PSWs. Thinking back, working with all those diverse groups probably is what helped me prep and really make me suitable for a career in consulting, because when you work in such a large organization, you almost become a consultant in some ways. You're always working with different groups, so it's kind of like working with different clients. So one of my tasks there was, it always seemed to be related to training for every department. So training and education was always seemed to be that commonality between the different groups. And our goal was always trying to help prevent injuries. In some cases, you end up seeming like you're being reactive, an injury has already happened and now you're going in and doing training, but the goal was really always to be preventive. And it made sense in many ways that seemed to be, one of the main gaps. It's like, why are our staff getting injured? What can we do about it? So ultimately we were trying to provide education and training, because it wasn't, even if we were to provide new equipment, we still would provide training on it to make sure everybody was using it properly and knew how to use it. So like, as you know, MSDs, the musculoskeletal disorders, are the leading type of workplace. So hospitals, the healthcare industry in general, there's no different in this trend. It's a huge cost. So on that note, let us move on and talk about the webinar outline for today. I want to highlight a little bit more about some of those injury trends, and then we'll go through really what makes up a successful program. So, you want to look at what you're currently doing to really know where you need to go in the future. So that's kind of our outline for today. If we look at industry trends, MSDs account for more than 40% of workplace injuries in Ontario, and this is the same for healthcare. There's no difference there. And in fact, in some cases, it can be a little more, a little less, depending on your specific organization. And, I'm assuming that most of you probably know where your injuries fall. I would doubt that you're much further from that 40% average. When we look at some of the details, you can see that most of those injuries are related to overexertion, which we can attribute to patient handling type of tasks. And the leading cause of lost time injuries, which is a huge cost to employers, right? It's millions of dollars that we're spending on these types of injuries. But because we're looking at them and they're related to overexertion, what that kind of flags to me and probably to many of you is that they could possibly be prevented, right? These are a good chunk of these are preventable injuries. If we're not overexerting, if we can work smarter and not necessarily harder, so, that's kind of a good slogan when we talk about ergonomics, then we could probably prevent a lot of these injuries and save a lot of money. And that's where I think that ergonomics is a really good fit when we talk about patient handling. We talk about training and education and implementing programs, and ergonomics fits really well into that, because the goal of ergonomics is to help people work better with their system. So to work better with the tools, the equipment, to perform their job tasks in better postures. And again, like I mentioned, that slogan, it's to work smarter and not harder. So I think before you really can figure out where you need to go with your current program, or with your future program, or what your next steps are going to be, you want to identify your current state. So, the goal of any kind of a minimal lift program or a policy that might be in place is you're trying to provide employees with a policy that promotes an environment where they use assistive equipment, where they're encouraged to use it, where it's expected to be used. And sometimes we go through the motions of putting together these types of programs, but is what we're doing actually working? Is it effective at achieving the goal you intended? So, that's a question where you want to start with is what are your goals? I'm assuming, and I'm not even assuming, I know that for many of you that goal is to reduce injuries. And you probably have a lot of other sub-goals that go along with that. But no, what are your specific goals for your organization? And again, knowing that, we go through the motions, we don't necessarily, we don't always spend time on, really doing the measuring or figuring out what's working. So it's really, that's all too common, and it's a good idea to start with maybe conducting a gap analysis or a needs assessment. That can be a really great starting point. So whether you're at the very beginning of your process or even as a midway point or that checkpoint to see where improvements can be made, you want to know, what are you doing now? What's been done in the past? Have you tried a minimal lift program in the past and it flopped? What were your thoughts on why it worked or why it didn't work? You're really trying to identify the root cause. There's a lot of common, you will hear excuse or reason after reason. Patients, they're too unpredictable. That's always, people are always going to mention, we can't have a no lift policy because patients, they're unpredictable. We have to be able to lift patients. Well, okay, I don't necessarily think that is the best answer. I can understand that might be a reason, but is it workload? Is it the work environment? Is it the layout? Is it the equipment that's available? Is it not the right equipment? Is it inaccessible, the equipment? Is it stored in it's stored down the hall, which it's going to take you 10 minutes to even go and get, and you have to dig it out of the room? There's lots of things that could possibly have contributed to why a program was unsuccessful in the past. So I think that before you look at what your next steps are going to be, you really want to try to identify the root cause of some problems that you may have had to know where you're going to make changes. And as well, you want to look at those root causes of why it was successful, right? Because that's going to help you if you want to now deploy this program to a different department or, something like that. You want to know, what was it that really worked well here? So the key elements of a successful program, really, if we're talking about best practice, you can go out there, you can talk to different organizations, find out what they're doing. You can do a Google search. You'll find a lot of different programs and policies out there. And, and I've done this. I've helped develop a program in the past. I've tried, even when we're not talking about patient lifting, we look at any kind of an ergonomic type of program for corporate wide. Any Google searches, and these are some of the commonalities that I found. So in terms of programs that are actually seeing success, and when I say success, I mean they are seeing a reduction in injuries related to patient handling. They are seeing a cost savings. They are seeing increased engagement with their employees. These are the key elements. So starting with commitment, so having the organization's commitment, having a collaborative approach, so multiple groups working together. They are providing education and training. They are measuring what they're doing, and they have visibility. The program is very visible. People in the organization know about the program, and people they're appreciated, the people who are involved in the program. So I'm going to spend the next couple of slides going through these in a little bit more detail. So we'll start with commitment, and this is a given. So it's absolutely the success and sustainability of a program are going to depend on the support of your top-down management team. Take a look at your organization's top strategic goals. Is there any mention of health and safety or injury prevention for your staff? These are really those key indicators on the senior management's seriousness and their level of commitment when it comes to implementing and supporting a safe patient handling program. If it's not in your top strategic goals, the chances of you getting that financial support, of them being on board, them being able to commit the time and the resources to do a program like this, the chances are slim. So you want to make sure that you're getting that support from the top down. And then maybe you start with a policy statement. It's a simple tool. It provides guiding principles, objectives, the goals. It doesn't have to be super long, but it helps to allocate the duties and the responsibilities, and it allows for the streamlining and helps with that decision-making process. Now, a policy statement on its own, it's a good starting point overall to build to your goal, but it doesn't really mean much if nothing further is done with it, right? So it can actually show a further lack of commitment if your organization's actions aren't matching what they're saying that they're doing in their policy statement. So again, we're trying to make sure that we're connecting all the dots here. If you've got the support, you've got the statement, we want to make sure that all the actions that are happening after that fall in line. And your policy statement is also going to be that springboard for any additional documents that are created. But again, keep in mind that I'm not just saying that your successful program has to have this paperwork standpoint. And so your program isn't going to be successful just because it looks perfect on paper. So you're going to need to have a very comprehensive program, right? So you're going to have your management on board. You're going to have done your gap analysis so that you know where you need to go, deciding what type of controls and equipment you might need. So really one of the main benefits that I see in a policy statement and some of those other supporting documents is that it's providing that consistent reference point. So these are the documents that you can always go back to. You can ensure consistency as you get staff changeover, management changeover. We know that we're always going back to that same document, and we know that our goals have remained the same. So our actions should always be in line with our goals. As with any project, nothing can truly be accomplished without a project leader. I strongly believe this. So there needs to be a person most responsible or a project manager to drive the program. When we make it too many people's responsibilities, I mean, I see this time and time again. If it's too many people's responsibility, it often seems like it's no one's responsibility. So we've seen a lot of flops as a result of this type of error in planning. And really, it's not to say that just one person has to lead it. It can still be a group, but you need to have a person or a group that, you know, everybody in your organization knows is responsible for that, and they're the ones who are driving it and leading it, just so that you've got somebody who is taking charge. So ideally at this team of people, you want to have people at the table who are going to help drive your program. It's especially important in a large organization because it can be really, I mean, too much for just one person to take on solo. I know many people who are who registered for today. I know that your role is like health and safety coordinator or something along those lines, and you wear many hats. You're expected to do a lot of things. So if you were to take on a patient handling program all on your own, it would be overwhelming. It can be almost a full-time job. So it really, having a team that's working towards that common goal is really critical. And you want to make sure that your team helps you to ensure that consistency. It's going to be better for sustainability as well. So, I mean, if you only had one main person who is driving and running the program, so this one person who did all the training, they seem to be the one who always knows what's going on, and they're kind of that go-to person. Like, what happens if they leave? For whatever reason, but what happens to your program if they aren't there anymore? So it's another good reason on, again, going back to having that supporting documentation in place, but it's also the huge benefit if you have a team of people who can speak to the details of the program and to be able to provide the training or maintain the support and really maintain the excitement of the program. It just can't fall on one person's shoulders if you're looking for long-term success. So my question to you guys now, for you all tuning in, is an opportunity to use the chat bar. But if you're thinking about who should be at the table, what are your thoughts? Maybe you already have a program in place, but who are some of the key people that you think should be at the table in terms of a project team for a safe patient handling program? So I'll just leave it open to for any chats to come in here, and we'll see if you guys want to respond in terms of who should be at the table. So remember, like, we want these people to get together. They're setting the reference on how, you know, your team is going to function, how it's going to implement the program. Okay, so we've got some people coming in. So your joint health and safety member, great answer. Definitely, that would be a really good person to have at this team, because they are somebody, they go around and they hear some of the health and safety issues. Often they are frontline staff, and they are also the ones who are going out and conducting workplace inspections. Okay, maybe some other people like yourselves, the people who are logged in today. If you're the health and safety coordinator, you're the ergonomist, maybe you're the, oh, I've seen some creative titles out there, musculoskeletal injury prevention coordinator. I think it would be really important as well that if you had some frontline staff involved, so some of your nursing staff, maybe the PSWs, getting them involved, it'd be really important to hear their feedback on what they think could work or what some of the needs are for training. Definitely you're going to want to have some managers on board. I think that would be some key people to sit at the table as well. And then that team might look a little different between different organizations, but possibly in that frontline staff mix, maybe you have some of your physios, your occupational therapists, or your kinesiologists. They might be good people to come to the table as well. Educators, again, depending on the size of your organization, you might have people who are already championing some of the education on the unit. So, you know, the people who are organizing I'm trying to think, some of the more clinical or the infection control type of training, right? Not always just patient handling training, but some of the more clinical education. You might want to have some of your facilities and maybe housekeeping or laundry involved. That would be good, because they're the ones who are maintaining the equipment, right? So if you're talking about mechanical lifts and you've got all these people, you're sending the slings out to be cleaned, and those are the ones who are inspecting them. Having those people at the table would be good too for, you know, just thinking about logistics of a program. So if we're going to bring in more lifting equipment and we want to make sure it's used more frequently, having those people at the table are going to be really key, because they're the ones who are going to help make sure that equipment is available for the staff. And then possibly you might want to have purchasing and vendors, even some vendors at the table as well, to make sure that you're consistent in what kind of comes into your facility, and knowing what kind of new products are out there, or if there's different tools, different slings even that you can use for different types of patients. Like I know with ceiling lifts in particular, you can buy different bars or attachments and different slings. I mean, the most often is that you're picking somebody up in a seated position, but there's even different tools where you can pick them up in a completely supine position, right? And it's just a quick little quick attachment or a quick connect, I think, and you switch out the bar on that ceiling lift. So sometimes people like that can be really good to bring to your table as well. So one of the next main components of a successful program, I think it's relatively an obvious component, I think, of a safe patient handling program. But note that in order for your program as a whole to be successful, training is really just one element. Remember that it's a program you're trying to create, so training alone might be helpful short term, but if you're going to be, it has to be supported with other elements to make sure that it's successful and really to make sure it's effective, which ultimately your goal is injury reduction. And if you want sustainability in the long term, the training is really one element of an entire program. I think, though, in general, from my experience and from what I've talked with other clients and other companies who have implemented these programs, that education and training is probably one of the more time-consuming elements. It seems like it is, you could argue that it's maybe the most important part, but the training and education really only comes from having those other building blocks. So, I mean, part of your initial assessment of your current state might look at how training is currently delivered and really trying to identify factors that are working or that need improvement. So it can be a really important discussion to have in terms of how are you going to disseminate the training? Who's going to provide it? So we've seen a few different models that work. And it's not to say that one is better than the other, but it's going to depend on your organization. But so sometimes it's one person or a small group. So for example, some specific titles. It could be a group usually of like the occupational therapists, physiotherapists, the KINs. And they are the ones who are doing that training. They all do all the training for the frontline staff. So it's kind of this small little group that seems to organize the training. Or we've also seen it where you have champions or designates on each unit. And I've seen them have different titles: champions, leaders. Maybe they're I think champions is probably one of the words that I've heard the most often. But they are specific. They are based on that unit. And they're the go-to person for training. They provide training for their unit. So it's way more of a train the trainer type of model. So sometimes it could be the OT or the PT, even an outside vendor who has provided them with the training, and then they're passing that along to their unit colleagues, so the frontline staff directly on their unit. So the style that you choose is ultimately up to you and what you think will work for your organization. And again, that's why that initial assessment, that gap assessment, is going to be important. So what type of training has worked for you in the past and what hasn't? And you can look at other training models. It doesn't just have to be when it's come to patient lift training, but looking at, any kind of training program that you've implemented, what works? How do your staff respond the best? So you want to really look at what's been tried in the past and look at your other successful training initiatives. Personally, from experience, I like the idea of the majority of the training coming from one specific group of people. So like the KINs or the ergos, the OTs, the PTs, and for several reasons. I mean, one, I really feel that this adds to the consistency of your program. You can be confident that that same overall message is coming through and being passed to your staff. And I like the idea of this type of group really delivering the training based on their educational background. So most of them will have a kinesiology or a human factors type of background, and they tend to be more likely to be attentive to body mechanic principles. So based on, based on their educational background and their general work experience. And it's not to say that other professions couldn't deliver this training successfully, but it's just been my experience, and I'm in general, and I realize this is a bit of a stereotypical statement, but most frontline nursing staff, they are experts in patient care. They know a ton about patient care, and they make the patient a priority, and that's great. It's always their concern. They're a caregiver through and through, but sometimes they can find it challenging to take a step back and look at their own needs. So this can apply in all different types of situations, right? If you think about, when even yourself, when you're involved in a project, you're so deep in the process, or you're so used to doing something a certain way, it can be hard to take a step back and see things from a new perspective, or to think outside the box. So again, that's another one of the reasons why I like a specific group delivering the training. Just it's an outside of a set of eyes that can be refreshing. And again, it's primarily because I often feel like the nursing staff they're always thinking about the patient, and they can't step back and just think about, how could they do it another way that would be an improvement for their body and still be great in providing great care for their patient. So again, just to kind of dive into that more, is this outside set of eyes is what I really feel that means is trying to add an ergonomic perspective to your training. So thinking about some of the core ergonomic principles, the three main risk factors when we do an ergonomic risk assessment really are force, posture, and repetition. We call those the big three. And these principles really should be incorporated into your training. You can, if we look at force is, it could be lifting patient limbs, it could be turning patients, it could be pushing beds and stretchers. All of those things are forceful activities. And posture is a really big deal when it comes to handling, like moving patients and doing patient care tasks. So you can think about, picture a nurse, they're stooping at the patient's bedsides for all kinds of tasks, like taking their blood pressure or changing dressings, helping them with showering and toileting in really tight spaces. They twisting, they're bending. Sometimes I think that nurses probably feel like they're contortionists at some point. So repetition or duration is that third of the big three ergonomic risk factors. And that's so how often a task is being done or for how long it's being done. And we have this discussion over and over again, but each of these factors on their own aren't necessarily a major concern. But once you start combining them, so once you start doing a forceful activity such as a patient transfer and you're using poor postures, that's when their risk of injury is really starting to increase exponentially for your staff. So the goal of your training is really trying to figure out how can they use equipment effectively, or how can they do a task a little bit differently where they're putting themselves in a better posture, right? Using the equipment is going to help them to reduce the force or the exertion, and then really trying to think about the mechanics, their body mechanics that they're using to make sure that they're minimizing the amount of time in bad postures. So this is where I really think that training, like patient handling training, can grow and improve, is when you start incorporating these principles and you're using mechanical lifts, you're doing your patient care tasks. I mean, just teaching people on how to use good body mechanics alone isn't going to be enough to prevent injuries. We need to make sure that staff are using the mechanical lifts, like ceiling lifts, floor lifts. Make sure that they're using assistive devices like pivot discs or slider sheets. The list goes on and on. Transfer boards, and not only making sure that they're using them, but then making sure that they're using them properly from that body mechanic perspective. Okay, so moving along in terms of other elements that make up a successful program is, we'll call it metrics. So it's measuring. So you want to have ways that to measure your progress, measuring your success. And using data of various types is really going to help you to do that comparison at the various states during your program, during that rollout phase. So most often companies will have some baseline data, like that you probably have some injury statistics. Ideally, you've got them there where they're kind of broken out by unit, again, depending on how big your organization is. And hopefully you've got them categorized as well so that you know kind of percentage-wise how many are related to patient handling tasks, etc. And then hopefully you have some other data as well. Maybe you have some equipment usage stats. That would be really handy. So knowing what equipment is available on each unit, how often it's used, those other kind of statistics beyond just the obvious injury statistics are going to be really important to have when you're doing those comparisons. So remember that musculoskeletal disorders, these MSDs, they're cumulative. They're happening over time. So if we're looking at doing some comparisons in our program at shorter intervals, like 6 months, 1 year, sometimes that's not enough time lapsed really to see a significant change in injuries. So when you're trying to present to, your upper management on, and they want to see numbers, they want to see injury reduction, they want to see dollars saved in injuries, sometimes that's not enough time to really show a significant cost, and you want to keep their support. You want to maintain the excitement of this program. So you want to look for other metrics that are going to help to show that your program is a success. So that's that other data, right? It can help with your short-term evaluations. That would be that equipment usage data. If you can show that your equipment usage is going up, well, that's a good indication that your program is doing well. You've been training staff. You can show them some of your training stats. We've invested this much time, this many resources in doing training, and we've correspondingly, we're seeing this increase in equipment usage. Great, right? Maybe we're not necessarily seeing that injury reduction yet, but we can hope that from these other positive statistics that we are seeing, that we will see injury reductions in the future. And then you might want to look at some other stats that you have, and I know lots of different organizations collect different things, but maybe even your employee engagement surveys can be good indicators, right? If you're putting an increased focus on staff safety, you're doing more training, you're kind of showing that you care more about the staff, perhaps they'll be reporting or a higher engagement, and that can be a really positive indicator on change in your overall workplace culture. So just look for ways that, I know injury statistics are always the first thing that we go to, but again, remember that injuries are going to take time to really see a reduction. And if you're looking for short-term measurements and wanting to show success, then we're going to need to look for some other data as well. So in my experience, and again, in talking with other people who are doing this, most often the people who are sitting on a patient or a safe patient handling program committee, they're not necessarily given any extra incentives to partake in that role. So I'm meaning like financial incentives. They're not getting a pay raise, they're not getting a bonus, they're not necessarily even getting additional time away from their regular duties to participate in the committee initiatives. So they might be allocated some additional time away, like especially in startup phase or whichever, but it's not always a significant amount of time to really cover the full requirement of them to be fully involved and committed, and that especially will start to show over long term. And the same goes for programs where they have the unit champions. So you have the people on each unit who are those go-to people for help or for training, that train the trainer model. And so often these people aren't given any additional incentives either. So how do we keep these key stakeholders engaged, right? They are the backbone of the program. We need them to be motivated. You need them to continue to want to participate because they're the ones who are leading this program. And, often when we launch something new, there's a lot of excitement in the first couple months, the first 6 months, the first year, and then things can start to dwindle as other priorities come up, or it's not new anymore. So we need to make sure that we're really looking at how are these people staying engaged. So I'm always asking this question. So whether it's a safe patient handling program, whether it's any kind of a program where it seems kind of new or different, and I know that I've seen them flop in other places, I'm asking people, what are you doing? What is it that, I want to know what your secret ingredient is, right? So what is it that keeps your committee members engaged? What makes them want to continue to participate And do you know what I hear more often than not? And I don't know, maybe this won't be a surprise to many of you, but it's, we show them our appreciation. And I said, okay, great. Now, how do you do that? And apparently it's food. No, and I'm joking a little bit, but a lot of the times that's, it doesn't have to be a large financial incentive necessarily to keep these people happy or to show appreciation, but it can take that form in many ways, and food just happens to be something that's a commonality. So it could be providing snacks or a lunch during meetings. It could be having celebrations for milestones. So when you do a launch, or when you hit a 3-month or a 6-month milestone, for example, maybe you have a cake and you're taking pictures. You really want to try to make that program visible so that people are appreciated, so that your whole organization knows what's going on, that these people really do feel like they are, they're taking extra time away from their tasks, they're putting in extra effort, but they're being appreciated, they're being recognized. So you want to use whatever you've got internally as well, like use your resources, take pictures, post information on your intranet, make posters, use those TV displays that you see when you walk into the hospitals now, you see big screen TVs everywhere. Use that to kind of share information, and then the public sees it as well. Memos, newsletters, any kind of media that you can use to make your program visible and really show the appreciation to this group can go a long way. Again, it doesn't always have to be a really big cost, but you want to make sure that program comes across as fun. Like you don't want it to come across as extra work. If people think that it's extra work, they're going to get tired of it real fast because they're going to start to expect something. But if you make it fun, you make it engaging, you really start to share some of those successes, then they're not necessarily going to see that as extra work. So, it's really amazing what a little note or a card saying thanks can do for a person. A smile can say 1,000 words. So you want to make sure that you really are showing appreciation to this group, because they are the backbone of your program. So those are kind of the key elements, but I wanted to touch on just another key piece of information or another strategy that you might want to consider in the early stages of planning, or even if you have a relatively good program in place, but you're wanting to take it up a notch. So in particular, if you've got all the key pieces in place, but your program's still not catching on, or if it's starting to dwindle, those types of things, this is the idea of a change management strategy. So nursing and caregiver tasks, they haven't really changed a whole lot. Yes, patients are getting bigger, the population is getting older, we've introduced some new equipment, some new technology, tools to help with caring for our patients, but the overall focus has remained the same. The patient is number one, and all of these new fandangly tools and equipment, often I hear the reasons why they're not using them as, oh, it'll take more time, or there's a zillion excuses or reasons that there might be. So I know that implementing a safe patient transfer program is no easy feat. You're trying to change behaviors, and that's a really big bite. That's a big undertaking. So I've really been taking a keen interest in change management models lately. I find that changing behaviors is really a key element in a lot of our ergonomic controls and recommendations that we do for our clients in all types of industries, not just healthcare. But you can give someone the most expensive piece of equipment. It can be fully loaded with automated features. It's going to make their job so much easier. But how do we get them to use it? Right? We have to encourage behavior change. We have to encourage a change in their habits. And this in particular comes into importance when we talk about changing postures. Something as simple, many of you are probably watching this while sitting at your computer. So I can give you the fanciest chair. It can have every adjustment feature on it and whichever, but if you don't know how to use it, or if you don't care to take the time to learn how to use it, I might as well just give you a stool. What would be the difference? I use that example a lot. So really, it's about you making a choice, you and the staff making a choice to do different behavior options. They have to choose different postures. And so this is kind of the flow. Changing behavior and habits is going to take time. So as much as we said, you're trying to look at your injury statistics, and it can take time for an injury to develop, and it can take time to show that injuries have reduced. You've seen a reduction in injuries. Changing behavior and habits is going to take time as well. So again, we might see an initial increase in the early stages of program implementation, and then maybe we see a plateau. But remember that it's not something that's going to happen overnight. We have to be consistent. We have to be persistent. So here is just like a general, the stages of change, really. So, often change management is really about proactively addressing the people-related risks that need to be managed in order to have a successful implementation. And it's going to require behavioral change in all aspects, not just your frontline staff. It's going to be your supervisors, your managers. It's going to be the support staff, the facilities, housekeeping. Really, all of them need to have some behavior changes in order to maximize the potential for this long-term sustainability. It's not going to happen overnight. And these are the general stages that people often go through, right? So they may not always start at number one there, the denial stage. It's kind of a continuum, so they can start in any not everyone's going to start there, but it's somewhat of a continuum. This phase is when they're in denial, they're not really accepting of why the change is needing to happen. I don't need to know how to use that ceiling lift. I'm just fine the way I've always been doing it. I've been working 20 years in the industry and I've had no injury. I'm not interested, right? We hear that a lot. And then this can start to sway into resistance, where people may realize that a change is needed, but they're skeptical. So maybe they're not comfortable with the new technology, so it maybe seems overwhelming to them. Maybe they don't quite fully understand the benefits or the pros. So, okay, the ceiling lift could be a good way to get my patient out of bed, but it's going to take me much longer. I'm just not sure it's the right idea for me. And then with some education, some encouragement, this can then turn into exploration. So they try the ceiling lift, right? Maybe they attend a session, they try it out, and they realize it's not really that difficult. And it does make it easier on their back. And hey, the patient was safe and the patient liked it. Great. So then this can then turn into commitment, which is regular use of your ceiling lift. And it's promotion of the ceiling lift to their colleagues. They're talking positively about it. This is like the ideal stage, right? So often we find that these stages are common when you're trying to introduce anything new. New foods in the market, yoga, exercise pitches, right? You name it, we can probably try to apply this to many different things. And it's important that we don't forget about the fact that when we are trying to do safe patient handling training, that we really are trying to change behaviors. And by no means am I a behavior change expert. I just find these models really intriguing. And in particular, the one that I have been looking at a lot more recently, and all of us at PROergonomics have been trying to incorporate this more into our training and recommendations is, this one change management, there's several models out there, but this one is by the PROC model, and it's called ADKAR. So those letters stand for awareness, desire, knowledge, ability, and reinforcement. And really, the awareness is awareness of that need to change, right? It's the why. It's why do I need to change? It's giving them that history on, okay, well, there's been injuries. Nursing is the, I heard that there's been a lot of healthcare events lately, and what I found really interesting is they're saying that nursing is one of the more dangerous professions out there, like even more dangerous than mining in terms of injury rate. So it's almost, I don't want to say that it's a scare tactic, but in some ways it can be. You're making them aware of that need to change, what's happening in the industry, what could happen to them, and then trying to influence them with the desire to participate and support the change. It needs to be their choice. And then knowledge of how to change. So what that change is going to look like, this is the learning process, right? So it's giving them the education on the tools that are out there or how to use them. And then ability flows into is implementing that change. So it's turning their knowledge, so everything that they've learned, and they're turning it into action, which is another element that you can incorporate into your training. So as much as we can sit here and tell people how to do something till they're blue in the face, but we need them to demonstrate it. We need them to act it out back to us to make sure that they really understand it, that they can apply their knowledge in the moment and in different situations. And then reinforcement is what's needed to keep that change in place. So that's when we talk about the celebrating of success. So I find that we can really apply this model to a safe patient handling program. These building blocks of this change management program, They actually align relatively well with those successful elements of a safe patient handling program that I've outlined throughout today. So, I mean, if this topic is of interest to you, I definitely encourage you to explore it in more detail and find some of those strategies that might work on turning maybe your existing program is okay, but turning it into a great one, really helping to advance it, or helping you to get over that speed bump in the road that is preventing you from moving that little bit further. So, just another little piece that I wanted